We have about 35 minutes left. I think what we've tried in this first hour, just over an hour, is to set the scene, give an update of where we are with these two important documents that will be shaping a lot of what happens in the malaria field over the next 15 years. And finally, some idea not just of the methodology used to set those targets, but also how much is all of this going to cost. What I propose we do now is we open up the floor, incorporating our panel members, Andrea Bosman, Tessa Knox, and Bernard Nallen, from whom I would actually ask to start with some opening statement of elements that you think may be particularly relevant and that may not have been sufficiently touched upon in this initial presentation. And following that, we will open up the floor for comments, suggestions, questions from all of you. So if I may ask to start with Bernard. Bernard, some quick thoughts or elements that you'd like to highlight.
No, I don't think it is this working? Can everyone hear me? Okay. Yeah, I don't have anything to add. I thought the overview was pretty complete. I was just sitting here thinking, for those of us who've been around in the world of malaria over the past 20 years, I still remember when the Abuja meeting took place, where the African ministers of health got together and talked about increasing coverage of bed nets to 50% and reducing, those were seen as being unrealistic at that point in time. Then a few years later, this was increased to 80% by the African ministers of health and Roback Malaria and the other partners. Again, that was seen as being unrealistic at that point in time. So when I sit here thinking, well, some of this stuff is going to be, some people may say this is unrealistic, but frankly, I don't think it is, because I think what we've seen in malaria over the past decade is that with appropriate technical guidance, not enough resources, but I continue to be impressed by how much countries have been able to do to drive down the burden of malaria, even with an ongoing significant funding gap. And that relies a lot on many people in this room and the countries themselves. So I guess what I'm trying to say is that these goals are not unrealistic. I think we can get there. It will be a challenge, the resource mobilization going forward. It's not only about the Sustainable Development Goals. Many of the other previous funders who were very much involved in the malaria fight, I'll just call it out, like the World Bank, now have other agendas, universal health access. Fortunately, the U.S. government remains committed for malaria-specific funding, in addition to funding to other parts of the health sector. So I think that with having high-level advocates like Bill Gates and others continuing to push this agenda, we will be able to move forward. It'll be a challenge, but we've come a lot farther than I think many of us thought we would have been a decade ago.
Thank you very much, Bernard. And very important, your note of optimism based on a 25-year experience of the malaria world. Andrea.
Thank you. We have seen the development of the Global Malaria Control Strategy in '91, which was based on 4 pillars. And some of them very solid are still remaining today in the new Global Technical Strategy, like the Pillar 1, which is calling for universal access to prevention, diagnosis and treatment. So we certainly build on a very solid foundation, but what comes very new in this strategy is the second pillar and the third pillar, which have been well explained by Pedro in the presentation, but they are really demanding major shift in the way we do malaria program support, normative work, research and implementation. So basically a strong agenda on elimination and very ambitious targets. We know how difficult it actually is to go after the last cases of malaria in countries which are really doing elimination. And the strategy actually calls for an acceleration of elimination. So it really demands new thinking of tools for detection of infections, for mass treatment of large population, preventive chemotherapy, and simply where we don't have yet the full guidance, but where a lot of research is expanding at the moment. And we have a lot of symposium in this Congress, actually, which dwell on these new technologies and new approaches. And the third pillar is also very interesting. It's the surveillance strengthening. We pushed with this through the T3 approach, but it's really a major challenge. We have poor quality data. We have inadequate surveillance system in most of the countries. Even in the countries where we have more malaria burden, we have more difficulty in getting the actual trends of malaria. So these are the two big, let's say, legs of the strategy, if I may say so, which will need that we do things in a very different way. And the targets are really ambitious, but they are, I would say, based on a very sound analysis of achievable. So I think that it opens up optimism, but also a lot of more work with the current partners, with the current alliance, and with a different, probably global architectures of moving this forward.
Thank you, Andrea. Thank you for highlighting how this builds on history, but also brings new and important elements to the table. Tessa.
So I just wanted to make some very brief comments, specifically about the vector control components of the GTS. As has already been outlined, the core focus of Pillar 1 is on maintaining coverage and maintaining the efficacy and effectiveness of our current interventions. But there is acknowledgement that there are some key challenges that we're facing in vector control. So we do have the challenge of insecticide resistance and also residual transmission. So this is any transmission that's remaining after your core interventions are being optimally deployed that won't be able to be influenced or affected by them. And of course, following on from that is this critical need for the development of new products. So products to address insecticide resistance and products to address residual transmission. And we've tried to integrate the need for better regulatory frameworks to be able to accelerate the availability of new products that do become available so that they can get to the countries as soon as possible. And we did quite a bit of work with the Innovative Vector Control Consortium on predicting when these will become available and trying to integrate those predictions of new tools into the coverage and the costing estimates.
Thank you very much, Tessa. So allow me to please to open up the floor for questions, comments, suggestions from all of you. They're welcome. We need them. Please, when you make your question, briefly introduce yourself before. Thank you very much.
Thank you. My name is Henry Lumens, physician and from Wisconsin. My question is for the individuals who anticipate fundraising for this project. Is there any idea of what percentage of the 115 billion will come from private donors, from governmental donors, and of the governmental donors, what percentage would come from the 97 countries that where malaria is endemic? And finally, of the governmental funding, what percentage of the gross domestic product of those countries who are funding this would that be?
Thank you very much. Perhaps we'll take 2 or 3 questions and then we'll get comments from these panel members. Thank you.
Hi, this is Candon Darren. I'm in the private sector myself, and I've been in the R&D business for over 20 years. And investors, when they're looking at a $100 billion price tag, are going to want to know what's in it for them. And I think, just as a commentary, I think we could do a much better job of posting the economic benefits of investing in malaria when over 600,000 children who are well nourished and could grow up to be economically sustainable adults are dying every year. And I think that's an important message that I'm not really hearing very much, that we could do a much better job. I think the second thing I ask is there a way, when we see those increasing costs over the next 15 years, is there a way that we can become more efficient so that we're not necessarily asking for so much money? Is there a way that we could change the way that we do business? So, for example, from an R&D perspective, it's wonderful that we have this conference once a year, but are there more efficient ways of communicating innovation and new information that comes out? Can we have a more open online sort of collaboration? So to that point, I've opened a website if anybody's interested in joining to have that conversation. It's open to any malaria researchers, and if a project is identified, we will get you the funding for that. So I welcome people to hop on that website.
Thanks a lot.
My name is Chichi Amajo, Community Vision Initiative, Nigeria. First of all, appreciating you all for your presentations and for these two great, amazing documents. Since we want to do things a bit differently, one thing that was highlighted was increased international and domestic financing. Yes, countries have done well, but we need to do more. Yeah, internationally, I know that is being taken care of. Can we look at no cap fits all, advocates in country to support financing? If we do that, the kind of thing that was done for Guinea worm, if this group will support countries, no cap fits all, I repeat, to find advocates. Alma has done so well in supporting various governments to come up with domestic financing. Until we have money in country, sustainability, equitable distribution will be an issue. Secondly is, I'm glad that cross-border issues are coming up now. Yeah, Eric mentioned South Africa, example of South Africa, and then Tanzania and other 4 countries. But a bloc like West Africa needs to be encouraged. Do we have a strategy to encourage various blocs? Realizing that drug pressure, anti-malaria medicines, the pressure is an issue. And like Tessa mentioned, we have a challenge with insecticide resistance. I don't know where we go from here. I'm glad we mentioned IVCC. These are the 2 things. Thank you.
Thank you very much. Let's perhaps start trying to answer or comment on some of these questions. I must confess, it didn't catch me entirely by surprise when you throw in a figure of 100 billion, that most of the questions should be around the funding. Hardly surprising. Problem is that I started looking around our members in the panel and say, who on earth is going to take this question? And David volunteered to do so. Clearly, questions around, great, you've made this exercise. Perhaps allow me in brackets to make some caveat or comments around this, but if you don't make them, you're accused of not making them. In other words, how much is all of this going to cost? Inevitably, you get made that question. If you make them, they say, well, yeah, it's good, but can you really predict that this is going to cost 100 billion? Can you really predict what it's going to cost 15 years from now? You're not allowing for innovation. You're not allowing for a whole set of things. So how meaningful are these figures? Close bracket. Having said that, where is the money going to come from? Can we make an investment case around this? Are there efficiencies, particularly in the innovation component, that could be brought forward? And I thank David for volunteering to have a first go at these questions.
Of course, I have easy answers for all those. Those of you who believe that are more foolish than I am. But clearly, we absolutely have to grow the total pie. We need more investment, more international investment. That will be challenging, certainly more domestic investment. What percentage of GDP, I don't know. And how we actually do that will be enormously challenging. But we do need to make a very solid case for that. And hopefully we will be in a world where, if we make the case, those investments will come forward. I would observe that the same issues came up when we launched the initial Global Malaria Action Plan, which actually included the global and regional strategies. You may recall that the figure was $5 to $7 billion a year, and people said, wow, that's, we'll never reach that. Well, we did not reach that, but I don't think that calling for that amount was off-putting. Now, $100 billion or $10 billion a year certainly is a very large amount, but if that's what we need, we need to aim to get that. Clearly, we'll have to make a case for investment. I think that can be done. I think you can fairly readily argue that malaria costs far more than that now. And if we get rid of malaria, we're saving a lot of money, and there are additional returns that come from those investments. Quantifying those is very challenging, but I do think that's a substantial argument. We have to be able to convince others. I agree also that efficiencies are needed, and that's something very difficult to include in the models at this time. That may be something we can incorporate. It's very easy for people to say, well, efficiency and effectiveness need to be improved, value for money, all these jargons that for which eyes tend to glaze over. But I think there really is substance there. We do have to figure out, for example, when we can withdraw safely vector control measures where those are not needed. Stratification is clearly a useful tool. We need to utilize it. So yes, we absolutely have to have more domestic financing. We have to look at ways in which programs have succeeded. I think guinea worm is a great example, not just in terms of financing, although that is challenging now, but also in terms of how that program is operated. Clearly, we have good mechanisms like ALMA. One thing I would call out is that I prefer to think of sort of transnational or inter-country efforts rather than cross-border. We're not just dealing with borders. We're dealing with countries, not just sharing a border, but sharing actually populations that move between those and a lot of things that are shared, not just on the borders. Finally, yes, drug and insecticide resistance, the pressure from parasite resistance and vector resistance are critical, and we're working very heavily with our partners, MMV and the Innovative Vector Control Consortium, and Nick Hammond is fortunately here with us. I'm sure there are colleagues from MMV here, I hope, who can speak to those efforts. So yes, those are all important, and I would encourage you to stay involved and provide us your input, examples, criticism as GMAP2 develops, and even as opportunities prevent for more input on GTS. Thanks.
Excellent. Let me give the floor to the mic in the back, and then, but don't go away, gentlemen. No, don't go away. Stay there.
Hi, can you hear me? My name is Maureen Kutsia. I'm from South Africa. I was very interested in the graph that was put up showing the costs of malaria interventions for the next 15, 20 years. And I noticed that vector control seems to take up about 50% of those costs going forward. And I presume that part of that has been included the monitoring and evaluation that has to go on with not only the implementation of the vector interventions, but also after you've eliminated malaria, you still got to carry on with your surveillance activities for the foreseeable future until malaria is eradicated globally. So my question is there any plan to accelerate the training of entomologists, particularly in Africa, because they just don't exist on the ground to do this kind of intensive surveillance that is absolutely necessary?
Thank you very much.
Yes, Graham Brown, University of Melbourne. I'm also interested in looking at the costs and noticed the very high cost of surveillance that is absolutely critical to control of infectious diseases. If we hark back to the SARS outbreaks and international attention that was drawn to SARS, countries reacted in various ways. China public health system said, yes, we need surveillance for SARS, but they decided to have surveillance of all communicable diseases, and this led to reporting of malaria, dramatic reductions in that country. Now, at the moment with the Ebola crisis, and of course many of the countries primarily affected also have malaria as well, and of course with febrile illnesses often will be a differential diagnosis of malaria. And of course there have been discussions to how malaria is not forgotten, which is probably more likely diagnosis in those areas if fever does occur. How are we ensuring as a malaria community that we are involved in the Ebola response and use this as a hook on which to improve surveillance and health systems for all of the infectious diseases? It appears that Nigeria, a high prevalence country for malaria, has done an outstanding job in preventing secondary cases of Ebola from a patient in the capital city. How are we ensuring that we're trying to improve generally surveillance of all these infectious diseases?
Thanks a lot. Thank you, sir.
Sixth, PMI Madagascar. I'm also talking about the numbers. When I look at the increase in funding or investment needed, you go from 6 to 9 billion. And we hope that we will eliminate malaria in 10 countries by 2025. So my question is, if you look at these numbers which keep going up, what happens after 2030? Can we expect, or can we, when you do advocacy, can you ensure that after 2030 the costs go down? That's my question.
Thank you very much. I think we have the first question that I'll direct to Tessa on a reflection on the importance of vector control and the weight it has on the overall cost, and the specific question around, does the plan contemplate specific training of entomologists? The second one I'll ask Andrea on the involvement on the Ebola response and the surveillance there, and what happens after 2030 in terms of the funding scenario. Richard, do you want to take that? Great. Tessa.
Okay. So regarding the high proportion of the costings that will be due to vector control, I think the current estimate is that about 45 to 55% of the expenditures in malaria control are for vector control, and this will be maintained or increased within the duration of this strategy. The surveillance is absolutely critical, especially as we're approaching lower levels of transmission, and we need to ensure that we're accurately targeting our interventions when there is a strong evidence base to potentially deviate from universal coverage. So this really emphasises that we need very, very strong systems, and as Maureen pointed out, strong systems require capacity. And I think it's widely acknowledged that there is a dire lack of entomological and vector control capacity at the country levels, also at the global level as well. And what we're currently doing is conducting a capacity assessment, and we linked this assessment with the World Malaria Report process to be able to collect country-based information on what capacity there is, because we really need the situation analysis to be able to design an appropriate training strategy and to direct the resources where they're needed. So for the entomological surveillance component of the GTS, it will include insecticide resistance monitoring, basic entomological surveillance, but there'll also be critically the monitoring of the effectiveness of the interventions as well. So all of this, as I said, requires the capacity, and we acknowledge that this really does need to be augmented and does need to be improved, and we hope to be able to take a strategic approach to improving this over the duration of the strategy.
Thank you. Andrea.
Thank you, Graham, for the question on Ebola. It's posing very strong challenges on malaria control in the affected countries at the moment. The first one has been really the need to move to presumptive treatment in a lot of facilities, in spite they had a high testing rate for malaria. And this is really to avoid the contamination with infected blood, potentially for the health workers. There has been major challenge in LLIN campaigns. One country, Liberia, actually postponed the campaign because of fear of contact with suspected Ebola patients. And luckily at the end, with a lot of work of coordination, it's back on track and they are starting the distribution. In some hotspots area for Ebola, MSF has started in Monrovia an MDA to bring down the incidence of fever and therefore reduce the burden to health facilities and the Ebola treatment units. So that the epidemic has demanded to adapt our strategies to the current, let's say, crisis, the current emergency. But you're totally right. There is a discussion of the post-Ebola phase where there will be a big need to rebuild the system, the surveillance, the testing, which was very good in these countries, and that is already something we are working at the moment. As you correctly pointed out, there is so much similarity between the initial phases of clinical presentation that has prompted a lot of thinking of how to improve, how to make triage, how to make even our testing, even the current microscopy, more safe in patients which potentially could have a very serious illness like Ebola. So this is all preparation for the post-Ebola phase, which should be really based on a declaration of interruption of the emergency by the respective countries.
Thank you very much. Richard?
So I'm pretty confident that if you see what we're spending our money on in 2025 to 30, it's going to be very different to the graph that I showed. As Pedro said, it's very uncertain predicting the future. Things will change, and the answer to a question, what's going to happen in the future, we don't really know. But what we're showing is our best estimate of what we think it is now. Probably what your question alludes to is maybe the GTS needs periodic updates every 5 years to take stock of where we are, both with intervention coverage, funding, so that we can adapt the strategy to prevailing circumstances.
Pedro has allowed me just a minute to highlight something that Graham called to my attention when he spoke, and that is what happened in Nigeria specifically. Lagos was remarkable, and I hope we all take that as a lesson. I had a malariologist in one of the regional consultations tell me that the fact that malaria could actually help strengthen health systems was basically BS. And I think what happened, the ability of the polio program to change on a dime and stop the spread of Ebola in Lagos, where we thought this was going to be a complete disaster, was quite remarkable and demonstrates the case we need to make about what we can do in terms of building health systems. And what Bill Gates said last night about the fact that this is not a dichotomy of vertical versus horizontal, we need both, is absolutely critical. So that's a lesson we need to learn and promulgate.
Thank you very much. Very important point. I think they're going to be the last two questions.
Okay, thanks. Caroline Jones from Kemry Wellcome Trust, Kilifi. Follows on a little bit from what was just said. It was very interesting in the introduction and the background about new approaches and a lot of rhetoric about multi-sectoral approaches, but I was a little bit disappointed that in the drafts of the two documents, particularly in the Global Technical Strategy, the mention of multi-sectoral approaches, improving housing as approaches, seems to have dropped out completely. And it's all based on the same old biotechnological approaches to malaria control. And I just wonder if there might be an opportunity to really put a little bit of innovation into these documents and include a little bit more reference to multi-sectoral approaches and the need to expand our vision in terms of malaria control away from just biotechnology fixes. Thanks.
Thank you.
Robert Brinkman from CHAI. I just had a question about resource mobilization as well. One of the things that we seem to have seen over the past decade with the enormous increase in resources for malaria in some countries is actually a substitution effect instead of a complementary effect where donor funding is actually not increasing the pie, as it were, but really causing a reallocation of government, endemic government funds to other priorities. So I was wondering what thinking has been done, if any, on how to ensure that resources are being increased both by domestic governments and by donors, rather than just kind of reallocating where it comes from.
Bernard, I think this latter one was clearly pointing at you.
Yeah, no, that's a crucial question. I just go back to, well, first of all, there are some countries in Africa that have started increasing their own direct funding to malaria programs. I use Zambia as an example. There's several others. So I think part of this gets into that dynamic that when governments themselves see there's a good return on investment, and that when you actually do something about malaria, you can. The nice thing about malaria, you don't need to wait years to start seeing some pretty substantial changes. So that creates a dynamic that if you scale up, prevention and diagnosis and treatment, you can show some pretty amazing impacts on the health of communities. I think the point we're trying to move toward is that documenting better that sort of return on investment, because most of us who work in the health sector, and I'm a physician, you look at the cases and deaths. There are different audiences out there, and it's not that ministers of finance don't care about cases of deaths, but they have all sorts of requests that are coming to them. I think going back to David's presentation, and Pedro pointed out also in the GTS, we need to figure out how to tell the story that goes beyond just the health benefits of controlling malaria. I called out the World Bank because they're the ones who talk to the ministers of finance. I think the development banks, the African Development Bank, the Asia Development Bank, are also important players in this, because we need their voice with the Minister of Finance, with their advice, and how to get the ministers of finance themselves to start putting more money into the health sector in general, but particularly in countries where malaria, the fight against malaria is not going to become less costly, it's going to become more costly. And these tend to be countries where there's not that much malaria left, and there's a danger that governments themselves will lose interest. So it's a common agenda. I don't have a simple answer to any of this, but it's an important issue that as we have external funding for malaria, that should be additional. It shouldn't replace what the governments themselves are doing and what other players in the countries themselves can do. You're probably aware that the Global Fund is also a big player in this, because as part of their new funding model, well, it existed before, but I think there's a bigger emphasis on actually looking at the additionality of the Global Fund investments to make sure that governments themselves, and there's actually some criteria for this based on the income level of the country, the governments themselves are investing more in the 3 diseases. So I'll just sort of stop there. I don't have I think going forward, it is about getting more funding from the national governments themselves. 6 of the 10 fastest growing economies in the world at the moment are in Africa. So I think some of these countries will become better positioned to put more of their own resources in. But one thing I do want to call out, because it's a real concern, there's a very crude approach to classifying countries based on GDP. You're probably aware that Kenya, for example, now is a middle-income country. And based on those criteria, Kenya will become less eligible for accessing global fund funding. That would be great if Kenya themselves put more of their own money into this gap-closing measures. But it gets into this equity issue. Those of us who are involved in malaria need to continue to call out that just because a country becomes wealthier, that doesn't mean that suddenly the people most at risk for malaria, which, as you all know, tend to be the poorest of the poor living in rural areas, are actually being reached with the goods. So we can't take our foot off the gas until we're reassured that that's happening.
Thank you very much, Bernard. I'll ask Erin to comment on the multi-sectorial approaches, how we've actually presented it, but there seems to be little translation into the actual document, and why that may be the case with regards to GTS, but how this surely will be covered within the GMAP2.
Right, sure. So as I mentioned, you should really see the GTS and the GMAP2 as companion documents, and we certainly don't want to repeat what is in the GMAP2 in the GTS. So actually some partners even called for these documents to be merged, and I don't think the decision hasn't been completely set in stone yet. But everything relating to the multisectoral approach will be covered in the GMAP2. There will be certainly more opportunities for all malaria partners in the wide global community to comment on that. That will be available online. So if people feel that there should be more technical guidance on multisectoral approach, I mean, you're certainly welcome to provide your input into that at the moment. I think there will be certainly bridges between the GTS and the GMAP2, but the GMAP2 covers its main focus is on the multisectoral approach.
Thank you very much. And Eric, as you have the microphone, can I actually ask you to bring to a closure this meeting? We're exactly on time, midday, and over to you to close.
Well, thank you very much for coming today, and it has been certainly a pleasure to see so many people interested in the development of both the global technical strategy and the GMAP2 going forward. As I said, we look forward to your inputs, certainly more into the GMAP2 than in the GTS, since it's at a much less advanced stage. But we have certainly some ambitious tasks at hand, and we have some more work to do to mobilize the community worldwide to achieve our goals. But as Bernard said, I mean, they have been achieved in the past, even though they were felt to be very ambitious. So we should all feel optimistic that these two can be attained in the future. So thank you very much for having come today, and hope to see you soon to give you progress and feedback on the development of the documents next year.
Thank you.